Okay, let's dive straight into a real medical mystery. Today, we're unpacking a phenomenon where a tumor acts like this covert saboteur inside the body. We're talking about paraneoplastic syndromes. It's this fascinating yet honestly devastating display of just how deeply interconnected our bodily systems truly are. It's like the tumor's wreaking havoc in places it has absolutely no physical contact with. So, you gotta wonder, how exactly does a tumor destroy tissue it has never even touched? Imagine a patient with lung cancer, right? Suddenly, they develop severe muscle weakness. Or maybe they start showing bizarre, rapidly progressing neurological symptoms, like dementia, or literally going blind. How is that even possible if the tumor hasn't actually spread or metastasized to the brain or the muscles? How on earth does this biological damage happen from miles away? Well, the answer lies right here in our core definition. Paraneoplastic syndromes are the remote effects of a cancer. Crucially, they are not caused by the tumor directly infiltrating surrounding tissue or sending out metastatic cells to distant organs. Instead, think of it as chemical or biological warfare from a distance. The tumor is hijacking the body's systemic pathways to deal its damage. To break this all down, we're going to hit 5 key areas today. First, the paraneoplastic phenomenon itself. Then, we'll look at the specific mechanisms of this saboteur, followed by the endocrine and neurological syndromes it causes, and finally, how we actually manage the sabotage. All right, let's jump into part 1, the paraneoplastic phenomenon, and specifically the usual suspects. Now, while a bunch of different malignancies can trigger these remote symptoms, there's definitely a pattern you'll want to watch out for. Keep your eyes peeled for small cell lung cancer, or SCLC. You're going to see those 4 letters pop up a lot today. It's our main usual suspect for this explainer, though you'll also notice cancers of the pancreas, prostate, breast, ovaries, and lymphomas frequently acting as the instigators. Moving right along to section 2, mechanisms of the saboteur, where we look at its 2 distinct methods of attack. So, how is the tumor pulling this off? Think of it operating in one of 2 ways. First up, we've got the rogue factory. This is where the tumor itself inappropriately pumps out hormones or growth factors directly into the bloodstream, completely trashing the body's delicate chemical balance. And the second method is friendly fire. This one is wild. The patient's own immune system makes antibodies to fight the tumor, but those antibodies get confused. They cross-react and attack normal healthy tissue instead. 2 completely different methods, but both lead to massive remote damage. That brings us to section 3, endocrine paraneoplastic syndromes. Let's look closely at that rogue factory mechanism. First up on the factory floor is SIADH, or syndrome of inappropriate antidiuretic hormone secretion. And look who it is right at the top of the common cancers list, our usual suspect, SCLC. In SIADH, the tumor basically pumps out antidiuretic hormone, forcing the body to hold on to way too much water. This heavily dilutes the blood, leading to a condition called hyponatremia, which is dangerously low sodium. Clinically, this looks like intense lethargy, severe confusion, and even seizures. To diagnose it, doctors are looking for that low sodium, low serum osmolality, meaning abnormally thin diluted blood, and ADH levels that are inappropriately high. To manage it, we have to aggressively fight the water retention, usually by restricting fluids to just half a liter to a liter a day, and sometimes bringing in medications like dimeclocycline. Next, we have Cushing syndrome. In this rogue factory scenario, the tumor, again, very often lung cancers like SCLC and NSCLC, secretes unregulated precursors to ACTH. This absolutely floods the patient's body with cortisol. Because of this, folks will present with acute sudden onset weakness, proximal myopathy, hyperpigmentation of the skin, and some really severe metabolic disturbances like hypokalemic alkalosis, which is a dangerous drop in potassium. Diagnostically, clinicians are hunting for sky-high ACTH levels that stubbornly refuse to drop, even when tested with dexamethasone. Managing this usually means going straight after the tumor itself with anti-tumor therapies, using drugs like metirapone to block the cortisol, or in extreme cases, completely removing the adrenal glands. Now, the really crucial thing to understand about our third endocrine syndrome, hypercalcemia, is distinguishing where it comes from. Yes, bone metastases can cause high calcium, but paraneoplastic hypercalcemia is different. It happens because tumors, often non-small cell lung cancers or squamous cell cancers, secrete something called PTHrP. That's PTH-related protein. It essentially mimics the body's normal parathyroid hormone, sucking calcium out of the bones and dumping it straight into the blood. Patients show up with rapid excessive urination, extreme thirst, severe dehydration, and literally life-threatening cardiac arrhythmias. On a blood test, you'll see a massive spike in serum calcium, over 2.7 millimoles per liter. But here's the kicker. The actual plasma PTH is low or undetectable because the healthy part of the body is frantically trying to shut the system down. Treatment here requires aggressive IV hydration and bisphosphonates to force that calcium back down. All right, moving on to Section 4, Neurological Paraneoplastic Syndromes. This is where we get into the friendly fire. So the mechanism completely flips here. These neurological conditions happen mainly because the patient's own immune system ramps up to fight the cancer, turning out specialized anti-tumor antibodies. But in a really tragic case of mistaken identity, these antibodies cross-react with normal, healthy nervous tissue. The most common presentations we end up seeing are peripheral neuropathy, which is nerve damage in the extremities, and proximal myopathy, meaning muscle weakness closer to the core of the body. Let's break those down a bit more. Peripheral neuropathy is incredibly common in this space. It can actually fly under the radar and be asymptomatic for a while, driven by the slow degeneration of the nerve axons or demyelination. It can mess with your motor control, your sensory feelings, or even your automatic involuntary functions. Then you have encephalomyelitis. This is a severe, widespread inflammation of the brain and spinal cord. It's a slow, subacute, but relentlessly progressive inflammation around the blood vessels that destroys neurons in critical areas like the limbic system, the brainstem, and the spinal cord. And if you check out the cancers linked to this, SCLC and breast cancers repeatedly show up as the primary culprits pulling the trigger on this friendly fire. Honestly, it is terrifying how rapidly these tumors can induce severe neurological decay. Take paraneoplastic cerebellar degeneration, for example. It has a super rapid onset. The antibodies attack the cerebellum, leading to bilateral coordination issues, double vision, and eventually dementia. But maybe even more startling is cancer-associated retinopathy, or CAR, which is linked to SCLC, breast cancer, and melanoma. In this case, the antibodies literally target the retina itself. It starts as blurred vision or episodic vision loss and progresses all the way to painless, total blindness. The tumor never even touches the eye, yet it completely destroys the patient's sight. Finally, for the neurological category, we see some profound muscle weakness syndromes. A classic one is Lambert-Eaton myasthenic syndrome. Here, the antibodies directly sabotage the presynaptic neuromuscular junction. Basically, they block the calcium channels needed to release acetylcholine. In plain English, the nerve physically cannot tell the muscle to contract, which results in severe proximal muscle weakness. Similarly, we see inflammatory myopathies like dermatomyositis and polymyositis, where the immune system attacks the muscles directly, causing weakness, massive skin changes, and joint pain. And this brings us to what is probably the most sobering fact about these neurological syndromes. The source material distinctly notes a quote-unquote poor response to Rx, meaning a really poor response to treatment. You might be wondering why? Well, unlike the endocrine syndromes where removing the rogue hormone fixes the balance, in these neurological cases, once the physical architecture of the nerve is destroyed by those cross-reacting antibodies, the damage is often permanent. We can stop the attack, sure, but you can't just easily rebuild a degenerated neuron. So, what can we actually do? Let's cover Section 5. Managing the sabotage and treating the root cause. The clinical strategy here has a very strict hierarchy. Step 1 is always to aggressively treat the underlying cancer. You absolutely have to shut down that rogue factory or eliminate the source that the immune system is reacting to. Step 2 is initiating immunosuppression. The goal there is to quiet down that friendly fire and stop the cross-reacting antibodies from doing any more damage. And finally, Step 3. For very specific antibody-driven syndromes, like Lambert-Eaton, clinicians will utilize plasma exchange. This literally filters those attacking antibodies right out of the patient's blood, which can significantly increase the response rate. Understanding all of this is absolutely crucial, because these remote symptoms often show up way before the actual tumor is ever found. Recognizing them early can lead to rapid cancer detection and life-saving interventions. But as we wrap up this explainer, it leaves us with a pretty profound question. We're witnessing the incredible, terrifying power of the immune system to destroy healthy tissue while just trying to fight a tumor. It really makes you wonder, if we can learn to perfectly tame and control these specific autoimmune responses, could that be the future key to comprehensive cancer care? Could mastering the saboteur actually be the secret to curing the disease itself? Definitely something to think about.